Welcome to the Next Generation NCLEX-RN Q&A review session. Today we will practice high-yield questions, clinical judgment scenarios, and expert tips to help you ace the NCLEX-RN. Also, make it your goal to sharpen your test-taking skills and boost your readiness. Don't forget to subscribe and like this video if you find this content helpful.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's continue with the topic.
Let's proceed to our first case. This is a Bowtie question, and it's about the nurse caring for a 36-year-old male patient in the emergency department. The nurse's notes reads at 17:30, the client arrived at the emergency department by ambulance following a motor vehicle crash that caused blunt chest trauma and lacerations. Vital signs recorded are temperature 98.6 degrees Fahrenheit, heart rate 98 beats per minute, respiratory rate 28 breaths per minute and shallow, blood pressure 132/80, saturation of 87% on room air. The client is alert and oriented ×4, but complains of shortness of breath and chest pain, predominantly on the left side. Examination reveals S1 and S2 heart sounds are present. The chest shows extensive bruising, more severe on the left, with diminished breath sounds in the left lung compared to the right. The left thorax exhibits reduced movement relative to the right, and percussion of the left lung produces a hyper-resonant sound. The client has no prior history of respiratory issues. So your task is to complete the diagram by selecting from the choices below to specify what potential problem the client is likely experiencing, 2 nursing actions that are appropriate to take, and 2 parameters to monitor to determine the effectiveness of nursing actions. So the options for the potential condition are the following. There's pulmonary embolism, acute respiratory distress syndrome, pneumothorax, and fat embolism. So what do you think is the answer here? The correct answer here is pneumothorax, because the client's symptoms, blunt chest trauma, there's left-sided chest pain, shortness of breath, diminished breath sounds on the left, also hyperresonance on percussion, and the reduced thorax movement on the left and low oxygen saturation at 87% are classic signs of pneumothorax. And this is something that can happen when the air enters the pleural space, so it will cause the lung to collapse, which aligns with the trauma from the motor vehicle crash and the physical findings that we are seeing in this case. Now, what about pulmonary embolism? Why is this incorrect? Well, this is something that typically presents with sudden dyspnea, tachycardia, and hypoxia, but this is not associated with hyperresonance on percussion. Also, diminished breath sounds on one side or the reduced thorax movement. And remember that PE is caused by a blood clot blocking a pulmonary artery. It's not caused by trauma related air in the pleural space, so making it as an inconsistent option with the trauma and the findings that we are seeing in the case. Now, what about ARDS? Why is this incorrect? Well, this is something that involves bilateral lung involvement. There's going to be diffuse crackles, severe hypoxemia due to the fluid in the alveoli, and this is often going to happen after a trauma or sepsis. And the case that we are seeing here shows unilateral findings. It's only affecting the left lung. And the hyperresonance, rather than the crackles, rules out the ARDS. And lastly, we have fat embolism. Why is this incorrect? Well, obviously, this is something that you're going to link with long bone fractures. And this is something that will present with petechiae. There's going to be neurological changes, there's respiratory distress, but not unilateral diminished breath sounds or hyperresonance. And the absence of systemic signs and the trauma mechanism make this condition less likely to happen in this client, in our case. Now, what about the nursing interventions? So I want you to select those two appropriate nursing actions. And one of those actions is the getting ready for chest tube placement. This is our primary preparation here because this is going to restore the normal lung function and it will improve oxygenation, and this directly addresses the suspected condition. Now, the other action that you should select is to start supplemental oxygen prior to chest x-ray. Take a look into the case. The saturation is very low at 87% on room air. And so when you're providing supplemental oxygen, this is an immediate, non-invasive action that will hopefully improve oxygenation while we are waiting for the confirmation using that chest x-ray. All right. Now, why are the other options incorrect, such as performing suctioning? Well, suctioning is only important and appropriate for airway obstruction due to secretions. But in this case, there's no indication that there is excess secretions or there is airway blockage. And what we have is an issue of air that is in the pleural space, not the airway. So this is irrelevant. The other options, such as administer a bronchodilator via nebulizer, is only going to treat if there is bronchospasm in a case of asthma or COPD. And since our patient does not have any history of respiratory problems, and there is no indication that there is wheezing, and so this is not relevant as well. What we have is a collapsing lung, not about obstruction, not bronchospasm, so eliminate this. The other option, such as begin an IV heparin infusion, is only used when the client may have a pulmonary embolism to prevent the growth of the blood clots. But here there's no evidence of embolism. And what we have instead is a trauma causing lung collapse because of also the presence of the air that is accumulating in the pleural space. Now let's select those two correct parameters to monitor. So we have the options: output from chest tube drainage, signs of bleeding or bruising, vital signs, progress of wound healing, and activated partial thromboplastin time levels. So one of those correct answers here is output from the chest tube drainage, because after chest tube placement for the pneumothorax, monitoring the drainage, such as air or fluid, will help us assess if there is resolution of the client's issue. And if there is persistent air leakage or unexpected fluid, this could indicate some more complications. So this observation is a key indicator that the intervention, such as the placement of that chest tube, is actually successful. Now, the other parameter that you should be selecting is vital signs. This encompasses the respiratory rate, heart rate. Also, this is going to help measure the success of the oxygenation and the stability of the patient's oxygenation, I should say. And if there's going to be improvement in the respiratory rate and also with the saturation, of course, this is going to give us an idea that there is now progression. There is no deterioration of the client's condition after the chest tube has been placed. Now, one of those incorrect answers is signs of bleeding or bruising. Why is this incorrect? Even though the client has bruising from the trauma, but monitoring for the new bleeding or bruising is relevant only for anticoagulation therapy, especially when the client is going to be placed on heparin, but this is not applicable here. And the progress of wound healing, another incorrect option, this is a long-term concern for the lacerations, not an immediate parameter for assessing acute pneumothorax management. And again, this is unrelated to the effectiveness of oxygen or the chest tube insertion. Now, lastly, we have the APTT levels. So this is a laboratory test to monitor for anticoagulation when a client is being placed on heparin therapy. But since we are not going to apply heparin infusion, this is irrelevant, and also irrelevant to the treatment of pneumothorax. So for you to correctly answer this question, I want you to rule out those options that don't match the presentation, which is basically the pneumothorax. And so if you have selected PE, it lacks trauma-related unilateral findings. And take note about the ARDS. This is going to be bilateral. And the fat embolism involves systemic signs. There's going to be petechiae, which is not seen in this case. And for the nursing interventions, I want you to exclude those actions not related to the condition, such as suctioning secretions, because there are no secretions present. And the administration of bronchospasm is unrelated. We don't have an issue of airway obstruction, but rather we have an issue of a collapsing lung. And the administration of PE doesn't really point to the problem that we have identified, which is pneumothorax. Now for the parameters, I want you to discard those options tied to incorrect interventions. Again, APTT, that belongs to heparin administration, and long-term outcomes such as wound healing, this is also irrelevant. And of course, we're going to be left with the vital signs and output from the chest tube. Alrighty. So for this question, I want you to focus on the ABC framework to help you identify the urgent issues and the appropriate interventions that will address the common issue here, which is the pneumothorax. Again, when you are reviewing this case, you got to go by the ABC. So first, airway. The client's airway is intact. There is no mention of obstruction. Now for the breathing, this is where the problem is. There is compromise of the saturation at 87%. There is tachypnea at 28 breaths per minute. The breathing is shallow. There is diminished breath sounds. So you have to focus on interventions that improve oxygenation and resolve the cause by preparing the patient for the placement of that chest tube. Now, when you go to the circulation, take a look into the blood pressure. It's 132/80, slightly higher than normal. I understand there is pain, and heart rate 98. There is no immediate circulatory interventions that were actually needed this time, even though it can complicate later on if we are not addressing the breathing. And so we are not really prioritizing the circulation at this time. We are going to focus on the main issue, which is about breathing and the exchange of the gas, which is no longer maintained at this point. So for the matching of the interventions, I want you to make sure that you link the condition, especially the pneumothorax, to the interventions. So what we need to do, anticipate the placement of the chest tube to remove the air in the pleural space and to administer oxygen to correct the hypoxia. And you have to connect these two interventions to the parameters. So we need to select those observations that will be able to measure the interventions that we have applied to the client. Vital signs and checking on the drainage output. And you got to be careful in Bowtie. You have to avoid mismatching the condition, the interventions, and the parameters to monitor. So I hope that you were able to get all 5 items correctly.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX Review Crash Course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. All right, now let's dive into the topic.
Let's move on to our next one. We have our case of a matrix multiple choice. So it reads, a 64-year-old male patient diagnosed with chronic obstructive pulmonary disease a year ago relies on supplemental oxygen at home. Unable to drive due to his condition, he depends on his son to transport him to medical appointments. Today, he is seeing his primary healthcare provider for a routine follow-up visit. Your task: for each observation noted about the client, determine if the interventions implemented were effective, ineffective, or irrelevant. And so we have our patient observations. First one, it says, the client successfully quit smoking through a formal cessation program. What do you think about this? Is this effective, ineffective, or irrelevant? The answer to this is effective, because cessation of cigarette smoking is the cornerstone of COPD management. And quitting smoking slows disease progression. It will reduce exacerbation. It will also improve lung function over time. And successfully completing a formal cessation program demonstrates an effective intervention that directly supports the desired outcome of better COPD control. So your strategy here is to focus on the words that show clear success and connect them to the disease cause. And so when you see the phrase successfully quit smoking, note that this is a positive outcome, and since smoking is the main reason COPD is happening, stopping this is actually going to help. And also think about what COPD needs. It needs less lung damage, and also quitting fits that perfectly. Now, what about the second statement here? The client's peak expiratory flow rate has increased by 15% since starting a long-acting muscarinic antagonist inhaler. The answer to this is effective. Why is that? It's because it indicates that there is improvement of the airflow, which is a key goal in COPD management. And Remember about the long-acting muscarinic antagonists? These are medications that will help relax the bronchial smooth muscles. It will reduce the airway obstruction, and this is a measurable improvement, which shows the inhaler is effectively contributing to better respiratory function. Now, what you need to do in this phrase is to look for the number showing that there is improvement, and you have to tie them to the treatment that is being monitored. And so when you read that phrase, increased by 15%, so this is actually a good change. And remember that the peak expiratory flow rate, or the PEFR, this is a pulmonary function test that will show how well the air flows out. And remember that LAMAs are the medications that open the airway. So this matches a COPD goal. There is going to be better breathing. Now let's move forward to our third statement. It says, the client uses a humidifier at night to ease breathing, but he reports waking up with a dry mouth and no change in his morning cough. So I hope you were able to get the hint in this phrase. And so the answer is ineffective, because when a client uses a humidifier, this is supposed to moisten the airways and to reduce the irritation, potentially to ease the breathing or the cough. However, when this client wakes up with a dry mouth and saying that there's no improvement in the morning cough, which is a common COPD symptom, it suggests that it's not achieving the desired outcome of symptom relief. And so the intervention is not working effectively for this patient. So for this phrase, I want you to pay attention to the phrases that reflects it did not work, even if the idea of using a humidifier sounds good, because in itself, the humidifier was meant to help the breathing, but the outcome, which is dry mouth and no change in the morning cough, show it's not really helping the client. So do not let the intention trick you. You have to focus on the outcome. Now let's move on to our next statement. It says the client follows the prescribed inhaler regimen. Yes, obviously that is effective, because if the client is adherent to the prescribed inhaler regimen, it will help ensure that the client will have consistent delivery of medication to manage his or her symptoms and improve their own lung function. And so the behavior that we are noticing here supports the achievement of those desired outcomes, such as reduced shortness of breath and fewer signs of exacerbations. So I want you to stick to the plan supporting the big picture here. And here, following the inhaler regimen means the client is using the medicine, like the LAMA every day. And inhalers are also considered as a lifeline for the COPD, so keeping the symptoms down and also keeping the lungs working. Let's move on to our next item. It says the client walks to the front gate daily without experiencing worsening shortness of breath. That is quite obvious here. That is effective, because if they're able to do this activity without worsening dyspnea, it indicates improved functional capacity and control of their symptoms, which are desired outcomes in COPD management. And so this also suggests that the interventions, such as the use of the medications and exercises, are also effective. Let's move on to our next item. It says the client was prescribed a short-acting beta agonist inhaler for rescue use, but he uses it daily instead of as needed. The correct answer to that is ineffective, because short-acting beta agonists are intended for acute symptom relief in COPD. It's not meant for daily maintenance. And since this is reflecting overuse of the medication. It suggests poor symptom control and possibly persistent wheezing, which indicates that the client is not really able to control their manifestation. So this is going to be ineffective because the use is pretty much improper. Let's move on to the next one. The client requires dental restoration work. What do you think about this one? Talking about dental restoration, this is irrelevant because this is unrelated to COPD management. And we know that oral health is very important, especially in the management of COPD. But this observation does not directly impact the respiratory condition being evaluated. Now, what do we have here next? Let's have the last one. The client's inspiratory capacity has increased by 200 ml since starting diaphragmatic breathing exercises prescribed by a respiratory therapist. The answer is effective. Why is it? It's because the increase of the inspiratory capacity reflects improved lung expansion and efficiency in their breathing, which are goals of COPD management. And the diaphragmatic breathing exercises can help strengthen the respiratory muscles, which will also optimize breathing patterns. So this makes an effective intervention. Alrighty, let's have our 3rd out of 6 question. This is a multiple response grouping. So let's go to our scenario this time. It says a nurse examines the chart of a heart failure patient who 6 weeks prior received treatment for digoxin toxicity. The client's skin today is warm and dry with mild lower extremity edema noted. Vital signs show a temperature of 96.7 degrees Fahrenheit, heart rate of 80 beats per minute, respiratory rate of 18 breaths per minute, blood pressure of 118/84, and oxygen saturation of 95% on room air. Following treatment, the client was sent home weighing 170 pounds and advised to see their healthcare provider for follow-up. This visit marks a post-discharge checkup with the provider. So your task: for each body system listed below, choose the current assessment findings that suggest improvement in the client's condition, noting that multiple findings may apply to each system or function. So we have the systems: metabolic, cardiovascular, neurological, gastrointestinal. So let's tackle our first system, metabolic. What do you think about this? So we have options: weigh 164 pounds, serum potassium level of 3.8, serum magnesium level of 1.4. So let's look at weight of 164 pounds. Do you think that this is suggesting improvement in their condition after the dig toxicity? The correct answer to that is yes. Take a look into the patient's weight at the time of discharge. It was 170 pounds, right? And the current weight, which is 164, reflects a reduction of about, let's say how many pounds that is. That is 5 pounds? Yes. Or close to about like 5 pounds or 6 pounds. And in heart failure, remember that excess weight often indicates fluid retention, which can increase during digoxin toxicity due to the reduced cardiac output. And note that the decrease in weight suggests less fluid accumulation, which points to improved management of the heart failure and the recovery from the toxicity episode. And so the presence of only mild lower extremity edema also supports this one. And this indicates fluid status is better controlled compared to a potentially worse state during the time when this client had toxicity. Now let's move on to potassium level of 3.8. Do you think that this is an improvement? This is also reflecting that, because this is within the normal range. And remember that digoxin toxicity can be worsened by hypokalemia, because hypokalemia can enhance the digoxin's effects on the heart, potentially leading to arrhythmias. Even though the scenario did not specify the potassium levels during the time when the client had toxicity, but the treatment typically will address such kind of imbalance. And this is a value that is within the normal range, so it indicates stability and will also reduce the client's risk in developing toxicity to digoxin. Now, what about serum magnesium level of 1.4? Is this an improvement or not? Well, the answer is actually no, because the range for the magnesium is set at 100, not 100, but 1.7 to 2.2 milliequivalents per liter, and the client's level is way below than the normal range. And remember that low magnesium can contribute to digoxin toxicity and will lead to cardiac arrhythmias, which is both a concern in heart failure and the dig toxicity itself. Now, even when the treatment 6 weeks ago may have corrected the acute imbalances, but this low level also suggests a current problem that is potentially unresolved rather than an improvement. And this level does not indicate recovery from the toxicity episode or better heart failure control, because this level could still increase the risk of dig toxicity. So be mindful about the level here. Now let's move on to the cardiovascular system. What about the blood pressure of 120 over 84 mmHg? Is this effective? Yes. This reflects effective treatment or interventions after dig toxicity, because remember that with congestive heart failure, the blood pressure may fluctuate due to poor cardiac output. What I'm saying here is that the blood pressure will most likely go on the lower side, but it still fluctuates. And the reason is of that because the client may have still fluid overload, and the heart is not able to really pump effectively the excess fluid in the system. And so previously, the blood pressure could have been unstable due to the slow heart rate or some heart rhythm issues. Now this time, the range is within, the value is within the normal range. And this typically suggests that the heart is functioning adequately without any adverse effects of toxicity. And also, an indicator that there is good cardiac output as well. Now let's move on into digoxin level of 1.0 nanograms per ml. What do you think about this? Yes, this also reflects effective treatment, as we know that the therapeutic range is somewhere around 0.5 to 2.0 nanograms per ml, but usually we want to keep it a little bit narrower, like 0.5 to 1.0 nanograms for safety. And again, this is within the normal range, and possibly in the last 6 weeks, the level could have been elevated, right? And so the client may have those dig toxicity manifestations. Now let's move on to the heart rate of 76 beats per minute. This is within a range as well. This is also normal. And remember that with dig toxicity, let me check that off. Okay, so remember that with dig toxicity, this often leads to a slower heart rate. There's bradycardia, less than 60 beats per minute, due to its effect on the heart's electrical conduction system. And seeing this heart rate of 76 basically tells us that, yeah, it's within the range, that the client's toxicity to dig has already been under control. Let's move on to the neurological manifestations. First, says no complaints of visual problems. Is this a improvement? Yes, it is. Remember about dig toxicity, which frequently causes the visual symptoms. There's blurring of vision. Other patients will report vision changes such as colored halos around light. This is due to the impact of the digoxin on the nervous system. And so these manifestations were likely present during the toxicity episode 6 weeks ago, because these are common indicators. And now the absence of visual complaints suggests the toxic levels have decreased and the neurological function has also stabilized. Now let's move on to the next assessment finding. It says no headaches in 3 weeks. What do you think about this? Well, this is not an improvement. It doesn't really reflect an improvement because headaches are not a primary feature of DIG toxicity, though these might occur indirectly in severe cases due to factors like low oxygen levels. But in this scenario, it doesn't mention headaches during the toxicity episode. And take note that in heart failure, the headaches are not consistent symptom to DIG toxicity, right? So this is something that you could associate with possibly high blood pressure, which is not present in the case. Now, moving into the next observation, it says reports improved memory over the past month. Do you think this is an improvement? Well, it is not, because confusion can, even though confusion may happen with DIG toxicity, we're talking about disorientation, right? Which is normally, it is an expected manifestation. But when we are talking about improved memory, that is a totally different thing. This is not a well-defined symptom of DIG tox. And even with heart failure, it might lead to mild cognitive changes from reduced blood flow, but the scenario does not note memory problems during toxicity. And this is also a subjective report, right? A subjective cue. And it also lacks a clear connection to either the condition or the intervention. So this is unrelated. So we are not going to check it off. Now let's move on to the gastrointestinal system. The first one is no nausea or vomiting in the past 4 weeks. What do you think about this? This is showing effective treatment, because remember that nausea and vomiting are common GI manifestations of DIG tox, and this results from the toxicity's effect in the brain's vomiting center and irritation in the bowel. And so these two, the nausea or vomiting, were likely present 6 weeks ago during the toxicity episode. And now that these two are absent, it indicates the digoxin level has returned to a safe range. Let's move on to the next two. It says reports of 3 episodes of diarrhea yesterday, 1 loose stool this morning. Is this effective? No, it isn't, because diarrhea is not a typical symptom of digoxin toxicity, though it might rarely occur in extreme cases or as a treatment side effect. But this finding points to a current issue. It is not a reflection of improvement. What about complaints of abdominal pain this morning? Do you think that this is improvement? Absolutely not, because abdominal pain is basically a sign of gut irritation, also associated with DIG toxicity. And the scenario that we have does not confirm its presence 6 weeks ago, but this manifestation is basically part of the DIG toxicity. And if it happened today, then it indicates that this is an unresolved issue or maybe a new problem. So I hope that you are able to remember those common common DIG toxicity manifestations in order for you to apply those in this case scenario. Let's move on to our next item, our number 4. It says, a nurse is attending to a 78-year-old patient at the primary care physician's office. The nurse is preparing a 32-year-old primary gravid client at 39 weeks gestation for an amniotomy to augment her labor. The client, who has been in active labor for 6 hours with contractions every 4 minutes, is at 5 centimeter cervical dilation and 80% effaced, with the fetal head at 0 station. Her membranes are intact and she has reported no complications during her pregnancy, though she mentions mild anxiety about the procedure. Fetal heart rate monitoring shows a baseline of 140 beats per minute with moderate variability and no decelerations. The client's vital signs are stable: temperature of 98.6 degrees Fahrenheit, pulse of 88 beats per minute, respirations 20, and blood pressure of 122/78. So here is your task. You are going to complete the statements and choose the words in those three options. We have options for blank one. It says leukocyte count, maternal blood pressure, fetal heart rate. Options for blank 2, ruptured membranes, compression of the umbilical cord, pain from uterine contractions. And options for blank 3, we have bacteria, prolapse of the umbilical cord, and anxiety. So let's complete this statement. The primary focus at this moment is to observe the blank. What do you think would best fit here? Well, the answer to this is fetal heart rate, because with the procedure amniotomy, which basically is breaking the water bag to help the labor move faster. And so right after the procedure, the nurse's role is to check the fetal heart rate because it will help show how the baby is doing. And before the procedure, the fetal heart rate was normal at 140 beats per minute with good fluctuation of the heart rate, I should say, and there are no decelerations. But once the fluid is gone, things like the problems that we're going to look for, cord slip out or maybe compression, could change that fetal heart rate. So this is going to cause that deceleration significantly. So when you're watching for the fetal heart rate here, it will help spot those that problem easily. So that's our priority. Now, what about the other options like leukocyte count? Why is this incorrect? Well, this is incorrect because this is only going to show the elevation or maybe a drop in the white blood cell count. But here, especially if there is a suspicion of infection, this is something that might happen after breaking the water if the labor takes too long. But the infection doesn't start right away. It takes hours or even days. And currently the client's temperature is 98.6 degrees Fahrenheit, which is within the normal range. So checking the white blood cell count is not urgent after the procedure because it's not about instant changes. It's not going to cause a rapid elevation of the white blood cell count. So your focus should be on the baby and the mother's condition right then, not a laboratory testing. Now, what about the maternal blood pressure? This is also incorrect. Remember that the blood pressure is 122/78, which is good for keeping blood flow to the baby and the placenta. Even though breaking the water might affect the blood pressure a little bit, but if the mom, this is something that's going to happen if the mom loses a lot of fluid or if they're going to feel more pain, but that's rare with a normal procedure and the vital signs were fine before. So we're not going to select this one. So let's proceed with the second statement. It says, which is most likely affected by blank or blank? So one of those answers, especially for blank 2, what do you think would best fit here? Well, that is going to be compression of the umbilical cord. Again, when the water breaks during the amniotomy, the fluid that protects the baby and cord goes away. And so this can let the umbilical cord get squeezed or compressed, especially with the contractions happening every 4 minutes. And if the cord gets compressed, it will cut down oxygen to the baby, which can show up signs such as drop in the fetal heart rate. And remember that the baby is still The fetal head is at 0 station and the labor is active. So this is a real risk right after the procedure. Now, what about the other options here? Ruptured membranes. Well, it simply means that water is broke, right? Which is what the nurse does on purpose with an amniotomy. And it's not a problem, but this is the plan. And the broken water doesn't directly mess with the fetal heart rate. What we're concerned about is what's going to happen to the baby after the water has been broken, right? So again, we're going to be worried about the compression. What about pain from uterine contractions? Why is this incorrect? Well, our client has contractions every 4 minutes, and it's getting stronger after the water breaks, which might make the mom feel more pain. But pain mostly bothers the mom and not the baby. And then in this case scenario, it only mentions mild anxiety, not severe pain. And the contractions could squeeze the cord a bit, but that's not the pain part. It is the pressure. And pain itself is not a top reason the fetal heart rate would change right after the procedure. So this is not the best answer. Now, the last option that we have, or the last statement, should be prolapse of the umbilical cord. That would be our answer, because the cord prolapse is going to occur when the umbilical cord slips down past the baby's head after the water breaks, which can happen with the amniotomy. And take a look into the client's or the baby's head station, 0, right? And the cord could get stuck against the mom's pelvis. It will block oxygen to the baby. And this shows up as a big fetal heart rate drop or a slow heart rate. And so watching the fetal heart rate will really monitor this fast, which is why it's the main thing that could affect it, along with the cord compression. Bacteria is incorrect, because this is something that we would be worried if an infection could happen after. But again, this takes time. It takes many hours, not minutes, and there's no sign of infection at this point. Now, what about anxiety? This is also incorrect, because the mom has mild anxiety about the procedure, which it might cause the maternal pulse elevate more. The baseline is 88. Take a look into the mom's respiratory rate of 20. That's within the range as well. However, if the client's anxiety would be much more severe, this might affect the baby's heart rate. But mild anxiety won't do a lot much in this case scenario. Okay, so that's why we are going to eliminate that. So I hope that you got all the blanks answered correctly.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month. Then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's jump into the topic.
Let's move on to our next item, number 5. This is a highlight or, yes, this is the highlight type of test item. It reads, the pediatric unit nurse reviews the admission nurse's notes and selected laboratory results from the emergency department for a 6-year-old child that has a history of an upper respiratory infection. So your task is to highlight significant data in the admission nurse's notes and laboratory values that should cause immediate concern to the pediatric nurse. So the nurse's notes says at 8:10 in the morning, arrived at the emergency department complaining of an intense headache that has become worse over the past 4 hours. The parent mentions the child had been receiving care for a cold-like illness for the previous 10 days and has finished their antibiotics. The parent says they gave acetaminophen 120 milligrams, yet it provided no comfort. They note the child attempted to rest flat and felt better briefly. The child is crying, not on any current meds. Skin feels dry, warm and dry. Breath sounds are faint but clear with coughing. Body temperature via rectum is 103.5 degrees Fahrenheit. Heart rate is 95 beats per minute. Respiratory rate is 20 breaths per minute. Spinal tap was performed prior to being admitted. And I want you to focus also into the laboratory tests. We have CSF with the white blood cells at 3 cells per microliter, glucose of 45 milligrams per deciliter, total protein 96 milligrams per deciliter. Appearance, that's cloudy. Serum sodium is 133. It's potassium 3.1. Leukocytes 13,500 per cubic millimeter. So get ready. I want you to highlight those important data. So one of those phrases is intense headache that has become worse over the past 4 hours. So a strong headache in this patient, a 6-year-old, isn't that normal, and this should take your attention. It could mean that something is very serious, possibly meningitis, especially since the child had a cold-like illness for 10 days, right? And they also had a spinal tap, which is the lumbar puncture. And remember about meningitis, it can start with a headache. It can get worse really quick. It will cause pressure onto the brain. And here, the nurse needs to act because this could be a sign of an ongoing infection that could have spread starting from as an upper respiratory infection. And remember that kids can get sicker really fast. So watching this could really help the nurse figure out if it's dangerous or not. Now, the next phrase that we should be highlighting is, of course, the statement says, become worse over the past 4 hours. So this is also a red flag, right? Because for this kid who had a recent upper respiratory tract infection, this could, again, point to something like meningitis or swelling of the brain, which is getting out of control. And this is something that is already progressing. So we need to control this worsening headache. Now, the next phrase is cold-like illness for the previous 10 days, right? So this is going to matter huge because it's been hanging around for quite some time. And now that the antibiotics have already been completed, and in children, an upper respiratory tract infection can sometimes lead to huge issues like the meningitis, or maybe a sinus infection, or it could somehow spread to the brain. And with the lumbar puncture that is already done, this should concern the nurse because this is a clue to why the child's so sick right at the moment. Maybe the infection moved somewhere else and it could have gotten worse. And the next one that you should highlight is the gave acetaminophen 120 milligrams, yet it provided no comfort. And it shows that the patient or the parents tried to help the headache, treat the headache rather, and also the fever. But since it didn't work, the nurse knows that this is not a simple issue, not a regular headache, which could be easily fixed by a acetaminophen. Now, another phrase that you should be highlighting is this: attempted to rest flat and felt better briefly. So, the word briefly makes this statement concerning because when they lie down for a short time, this is something that could point to meningitis as well. Because when they're going to lie down and if there is some relief for just a brief period, this is the kind of headache that usually will be assessed in a client with a meningitis. And of course, this is not really helping. It's just hiding the headache. So this will require more follow-up. Now, the next phrase that you should highlight here is this: breath sounds are faint but clear with coughing. So after a 10-day upper respiratory tract infection, the lungs should sound okay. But if it said faint, it could mean the child's breathing is, they're not able to take deep breaths deeply. Maybe it's from the pain, or maybe they're just exhausted, or there's still some kind of a lung infection going on that it was not quite controlled. So it's not that so bad, but since the client is having faint breath sounds, they're not getting enough air exchange. So this should trigger you to be worried about something else is going on. Now, what about the temperature? Of course, that is 103.5 degrees Fahrenheit taken rectally. This is way high, even for the skin, right? And the nurse will see this a sign of something bigger. Could be a major infection, could be meningitis, and since we are also worried about the spinal tap that has been done. And lastly, we have this one: spinal tap was performed prior to being admitted. This is also a red flag because this is a test that's not regularly done, right? This is a critical piece of information in the nurse's notes that will help signal the pediatric nurse that something significant about the child's condition is really being assessed or evaluated by the healthcare provider. And this is a huge deal. Again, this is not a usual test. So this is intended to check for any serious stuff like meningitis, especially with a prior upper respiratory tract infection. And they are currently having fever and severe headache. So again, this should hint you that something bad is really going on for this pediatric patient. Now, what about the CSF values? So one of those is the glucose of 45 milligrams per deciliter. Take a look into the reference value. It should be set at 50 to 80 milligrams per deciliter. And the client's value is lower than that range. So this is a red flag because a low glucose in the CSF points to bacterial meningitis, especially in a child with a recent upper respiratory tract infection, with high fever and worsening headache. And the reason why this is low because bacteria in the CSF consume glucose, and that's why the value is low. So this is typical to a bacterial type of meningitis, because with viral type of meningitis, glucose usually stay within the normal range. Now, what else do we have to worry here? Another is total protein of 96 milligrams per deciliter. Because this is way above the normal range of 15 to 60. And this should get your attention because a high protein in the CSF also signals inflammation or infection like meningitis, which fits with the client's symptoms and their lumbar tap history. And this is something that can happen when the blood-brain barrier gets leaky because of a current infection or due to the swelling. So it will let the proteins seep into the spinal fluid. And together, if it's paired with the headache and the fever, again, this is a serious concern. It hints at something like bacterial meningitis or possibly another neurologic emergency. What else do we have? An appearance of cloudiness also is a concern because typically CSF should be clear. And this should trigger you to jump out because this means that there is an active infection, particularly bacterial meningitis. And again, the cloudiness comes from the accumulation of white blood cells, bacteria, or pus in the cerebrospinal fluid. So this is nothing subtle at all. This is a visual clue that something's very wrong in this child. So you have to prioritize this significant finding. What else do we have going on? We have a sodium of 133 milliequivalents per liter. This is below the normal range of 135 to 145. And in a child with a possible infection like meningitis, a low sodium might hint at something like maybe a developing syndrome of inappropriate antidiuretic hormone secretion, right? Which is something that can happen with this possible meningitis. Yes, that's a complication. And it is a concern because it could worsen the brain swelling. It can lead to seizures if the sodium level drops even further, let's say in the 120s, right? Now, looking to the potassium, you think that this is significant? Yes, 3.1 milliequivalents is low for this client as well, because it could affect the client's heart function and muscle function. So this is possibly going to affect the heart rhythm in this child. Now, what else do we have? We have leukocytes of 13,500 per cubic millimeter. That's also a red flag. This is already elevated, a major concern, because this shows the body is fighting for the infection. And this fits perfectly with the fever, the upper respiratory infection history, and the cloudy CSF from the spinal tap. Again, this hints to a bacterial process like bacterial meningitis. So I hope that you were able to capture all these significant findings. Let's proceed to our last item. We have a case of a matrix multiple response. So you can check off maybe just one of the medication, or maybe two, or maybe all of the three medications per patient health teaching. So the case says a clinical preceptor nurse is educating a newly hired nurse on the medical unit about biologic response modifiers used to manage rheumatoid arthritis and other chronic autoimmune conditions, focusing on the key nursing responsibilities associated with the most commonly administered medications in this category. Your task is to identify the nursing implications and health education topics linked to three widely used biologic response modifiers, keeping in mind that some teaching points may apply to multiple drugs. So let's pay attention to the first health teaching or implication. It says, understand that this medication may increase the risk of developing cancer. What do you think about this one? Is this true to anakinra, etanercept, or infliximab? Well, for etanercept, or for the anakinra, this is correct, because the anakinra can block the interleukin-1, which is part of the immune system that fights inflammation. And according to research and also clinical trials for the rheumatoid arthritis, it shows a slight increase in cancer risk, possibly because the immune system, when weakened, it will miss those abnormal cells that could become cancerous. And your role here as a nurse is to let your patient know to watch for those signs like lumps, and they need to stay on top of their routine checkups for a possible appearance of new cancer. Now take a look for the etanercept. Do you think that this is true for etanercept as well? Yes, it's because the medication can also stop the tumor necrosis factor, which is another immune system component. And according to studies, including those reviewed by the FDA, It's also linked to cancers like lymphoma, especially in the younger patients, due to the suppression of their immune system. Again, your role is to educate your patient about keeping aware and making sure that they are being compliant to routine checkups if they get this medication. The third medication, do you think that this is also applicable to this one? Of course, this is also going to increase the risk of developing cancer because it also blocks tumor necrosis factor. And according to the clinical data and the drug warnings by the manufacturer, this medication also show a higher chance of malignancy, such as lymphoma, maybe skin cancer, because a less active immune system might not stop these rogue cells. Again, this is your role to educate the client about this precaution. Now let's have the second statement. It says, make sure you ask the healthcare provider to monitor your white blood cell count. You think that this is applicable to anakinra? Yes, it is. Because the anakinra can lower the white blood cell count. We call that as neutropenia, and this is something that has already been observed in up to 8% of patients in clinical studies. And according to the manufacturer, the white blood cell counts should be tested before starting the patient on this medication, then to be done monthly for 3 consecutive months. And after the first 3 months, the blood counts should be tested every 3 months for up to a year. So take note of that. For the etanercept, this is also correct. They need their white blood cell count monitored because the medication itself can reduce the white blood cell counts in rare cases, even rare cases. And this is also noted in post-marketing reports that patients also develop pancytopenia or leukopenia. Even though it's not that frequent, but monitoring will help avoid infection concerns. And that is your role as well. Now, what about the infliximab? This is also correct because the infliximab can decrease the white blood cell counts. According to the research, it showed that leukopenia has happened to some of the users due to immune suppression. And having their blood counts done regularly will help the client monitor their values as well. And this is going to encourage the client to keep their regular schedules in having their white blood cell count monitored as well to keep their defenses stronger. Now, the third statement, it says, notify your healthcare provider if you experience chest pain or trouble breathing during the drug infusion. Do you think that this is correct for anakinra? It isn't, because anakinra is not given as an IV infusion. This is a medication that is given via subcutaneous injection, and this is a drug that actually can be administered by maybe a parent or a family member to the client that is concerned. And they can be taught in administering this medication at home. And again, this is not administered as an IV infusion. So this is not going to cause chest pain that is caused by this kind of route. Same thing, or let me check that out. Whoops. Oh, so I made a mistake of actually checking it in advance. So for the etanercept, this is also untrue for the etanercept because this medication is given as a sub-Q injection as well. And without an infusion, there's no risk of infusion-related chest pain for this client. So now that you've already seen that infliximab has been checked off, this is correct because infliximab requires regular infusion schedule. The client should be showing up into the provider's clinic for the infusion or maybe into the infusion center. And it's known to cause chest pain or even shortness of breath during the infusion. And it has happened in about 20% of patients overall. And this sometimes can cause some serious respiratory issues. So you have to really emphasize this to your patient using this drug. And infliximab is often marketed as Remicade. I hope that you remember that brand name. The fourth statement, it says, store this medication in the refrigerator unless instructed otherwise. What do you think about this one for anakinra? Is this applicable? Yes, it is, because anakinra should be kept in the refrigerator at 2 to 8 degrees Celsius, and that is according to the manufacturer's instructions. And if anakinra is left unrefrigerated for more than 12 hours, it should be discarded. And again, it should be stored in its original container and away from light. And according to the studies, it shows that the medication loses its effectiveness if it is kept at room temperature for too long. So this is your responsibility to educate your patient according to this manufacturer instruction. Now for the etanercept, do you think that this is also going to be a check? Yes, it is, because it requires refrigeration at 2 to 8 degrees Celsius per the manufacturer. And before you administer the medication, it has to be taken out from the refrigerator, and it has to be at room temperature, about 20 degrees Celsius to 25 degrees Celsius, just before the administration. Now for the infliximab, do you think that this is supposed to be refrigerated? Yes, it is correct, because the vials are supposed to be kept at 2 to 8 degrees Celsius. And when the client is supposed to be ready and receiving the medication, that solution should be brought to the room temperature before its use. And this is done to reduce the discomfort during the infusion. So this is part of your teaching. But then again, the medication itself is to be stored in the refrigerator before the preparation and before the administration. Lastly, we have avoid receiving live vaccines while taking this medication. What do you think about this? For anakinra, this is true, because anakinra itself can weaken the immune system. It will block the interleukin-1. And according to clinical evidence, the anakinra actually could cause, if the patient will be receiving live measles or varicella, it could cause them infections instead of immunity. And for etanercept, the same is true for etanercept. The client should avoid getting live vaccines, because the vaccine itself, I mean, not the vaccine, but the etanercept, which is a biologic response modifier, can suppress the tumor necrosis factor. So it will lower their immune strength. And this can also lead to serious infections like a full-blown chickenpox if they get a live vaccine. For the infliximab, this is also true, because the medication can block the tumor necrosis factor. It will also reduce the immune system power, and it is confirmed by clinical studies that the live vaccines are also dangerous for this client receiving this infliximab. They will catch the disease instead of developing immunity. So this time, if you are not quite familiar with these medications, we're going to do a quick review of each. And so for the anakinra, this is usually prescribed as a daily medication because it has a short half-life, approximately about 4 to 6 hours. And the reason for this is to cause consistent suppression of the interleukin-1, which is a key inflammatory cytokine. And this daily injection schedule might be a drawback for a patient who dislikes injection compared to the other medications such as the infliximab. This is the anakinra itself will last for many months, even years, right? So for the rheumatoid arthritis, this is given for several months. depending on how well the patient is able to control, or how well the treatment is able to control the joint inflammation and the pain. And anakinra is considered as a second line biologic. So if it's going to be ineffective, the patient may be switched to alternatives like the etanercept or the infliximab. However, if the client is using the anakinra for the CAPS, this is what we call as the cryopyrin associated periodic syndromes, or CAPS. This is a rare genetic and autoinflammatory disorder, and with this condition, the client will require lifelong therapy, because CAPS in itself is a chronic condition driven by interleukin-1 overproduction. And so if they're going to stop taking the drug, this could lead to severe recurrence. They're going to end up with joint pain, severe rashes, and fevers. For the indications, as I have already mentioned, this is used for patients who are suffering rheumatoid arthritis. Also, the CAPS, that's the cryopyrin associated periodic syndromes, which is a chronic condition. And for the route of administration, this is given as a subcutaneous injection. Again, it's given daily, typically 100 milligrams for adults daily. So this is a straightforward method, but also requires patient commitment in order to maintain consistent routine. Now for the etanercept, this is a drug that is going to be given in this manner, once or twice weekly. This is a medication that is going to inhibit the tumor necrosis factor. And the once a week or twice weekly dose is standard for most conditions. And this is going to be administered for many years, sometimes indefinite, because this is used for chronic conditions like rheumatoid arthritis or psoriasis. And again, this is for long-term therapy. This can last for several years to keep the inflammation in check, and also make sure that you are teaching your client to check themselves for the possible effects such as infections, which is actually what I mentioned in the previous slide. Now, this is going to be indicated for so many conditions like RA, psoriasis or psoriatic arthritis, ankylosing spondylitis, plaque psoriasis, and the juvenile idiopathic arthritis. And for the route, this is administered as a subcutaneous injection. Again, this is administered once or twice a week via pre-filled syringes or maybe auto injectors, and this is quite convenient for the client who are wanting autonomy, for those patients who do not really want IV infusions. Now, lastly, we have the infliximab, which is marketed as Remicade. This is a drug that is given every 6 to 8 weeks after the induction, and this is intended to be given for several years, sometimes indefinite. And again, this will require long-term treatment, therapy commitment, because the conditions are quite chronic. And if there is going to be abrupt discontinuation, this can cause remission of a possible remission of a Crohn's disease, and the efficacy of the medication will drop significantly as well. So here are the indications: rheumatoid arthritis, Crohn's disease, ulcerative colitis, ankylosing spondylitis, and psoriatic arthritis, and plaque psoriasis. Now, the route, as I've mentioned earlier, this is administered as an IV infusion in an infusion center or the healthcare provider's clinic. It typically lasts about 2 to 3 hours per session. And I hope that you're able to catch on to the different modalities of the treatment of these inflammatory disturbances, and I hope that you were able to catch on the different implications and the patient health teachings that you should do once they or before they proceed with the therapy. And so that wraps up today's NCLEX review. So I want you to take some time to think about what you've absorbed, and I want you to work through these practice scenarios again and continue strengthening your test taking skills. And if this video was helpful, don't forget to hit the like button and subscribe for more NCLEX prep resources. And hopefully you're going to drop a comment below to tell us how well you did in these practice tests. And I'll see you again in the next coming video. Thank you.